Rahman Ar-Rahim. This video will clarify the examination of the knee joint. The examination of the knee joint is a weight-bearing joint. So you should start from the gait of the patient, the neutral gait of swing and stance phase. And a stiff knee gait is something different from this gait. Or the knee may go into varus or valgus thrust in case of ligamentous instability. Second, you have to examine the profile, the standing profile, the alignment of the lower limb, and front on the lateral and the posterior view. If there is flexion deformity or hyperextension, or in case of genovarum or genovalgus. You have to look the patient for the side view. Again, you have to perform certain stress loading tests to test the stability. You have to examine it on the normal side, and then you ask the patient to do a several twist on the disease side, see how is need to support himself by nearby object because of unstable right knee. The jump test, we ask the patient to jump on both legs, see if the patient is jumping correctly on a disease on the normal side, and then we'll do it on the isolated side. First we do it on the normal side, and then you do it on the normal side. See, he's afraid to put weight or jump on the right side. The staircase test is the test to use for testing the ACL, PCL, and the quadriceps muscle mechanism. First, we ask the patient to go with the normal leg up and down, and then we ask the patient to go up and down with the disease side and see the difference, how he is able to get up and down stairs depending on the integrity of the ligaments, PCL or ACL. We go PCL upward and quadriceps muscle, and while the ACL and quadriceps muscle will go downward. Deep squatting test is the test for the meniscus. The patient with the meniscal tear, he is unable to sit symmetrically like that, and we ask the patient to walk while he is in squatting position for the stability. Then we examine the patient in the sitting position for the following test: patellar sequence, patellar tracking. See, the patella is tracking on a straight line up and downward while the patient is flexing and extending his knee. And the second test is the Steinman test, is to palpate for the medial joint line tenderness or the medial meniscal tear where the leg is externally rotated, and palpating the lateral joint line from anterior to posterior for any tenderness in case of the lateral meniscal injury. The third is the Wilson test, is deep palpation on the area of osteochondral defect with compression by having extension, and the second with compressing by the thumb on laterally and extending the leg completely. In inspection, you have to inspect the skin, the soft tissue, you inspect the bone, deformity and the swelling, and on the palpation you have palpate the temperature by the dorsum of the hand, which is more sensitive than the palm, if there is any difference or the changes in the temperature. You have to palpate the soft tissue, the synovium, the quadriceps tendon, the patellar tendon, for any gap or rupture, and then you have to feel for the lateral collateral ligament and the medial collateral ligament. And then you have to test for the fluid by fluctuation test using both hands. The superior hand we call it squeezing hand, the inferior hand we call it watching hand. and the patellar tab, and the pulse test is to squeeze the fluid from the old compartment to see if there is any pulse medially, and halo test is to palpate the halo on both sides of the patellar tendon. You have to palpate also for the bony landmarks, the medial condyle and the femoral condyle and the tibial condyle. You have to palpate the patella for the patellar glide, medial and lateral, up and down. And then you have to feel the undersurface of the patella for chondromalacia patellae, squeezing the patella laterally for the lateral translation. And then you have to measure the muscle wasting. You have to measure the muscle wasting by the tape measure, measuring the girth of the thigh at 2 identical points on both sides, by means of the tape measure, to see the difference in the bulk of the thigh at the same level. So if the difference is less than 1 centimeter, we call it mild. If it is -2, we call it moderate. If it is -3 difference, we call it severe. Then you have to measure the Q angle or valgus angle. This angle is subtended between 2 straight lines. The first line is the anatomical axis from the anterior superior iliac spine to the center of the patella, extended distally. The second line is drawn from the mid-inguinal point, which is the point of palpable arterial pulsation, descending downward to the center of the patella. This line, which we call it a mechanical axis, would meet with the anatomical axis at the center of the patella, making an angle. We call it valgus angle. The normal angle is between 0 to 10 degrees. And this angle is measured by means of a goniometer. Don't forget to examine the apprehension test for the patellar stability. We support the knee of the patient on the knee of the examiner and pushing the knee laterally. The patient try to resist the maneuver by apprehension if he is having a dislocatable patella. And then you have to perform the full range, the range of motion, active range of motion, flexion and extension. The flexion is completely limited by attachment of the posterior skin of the calf to the skin of the thigh posteriorly, and the extension is around 180 degrees. You should compare it with the other side to compare the range of motion. Active range of motion is very important landmark for further examination of the knee joint. Otherwise, if the patient having no free motion, you cannot able to examine the knee if it is painful. This is extension test for the meniscus. We hold the knee in extension and we press over the anterior aspect of the knee. And this is the McMurray test for a chronically injured meniscus to elicit the click by palpable or audible click medially or laterally with severe, with extreme flexion and extension of the leg. This test requiring a relaxed patient and relaxed surgeon. Then testing for the collateral ligament by stress valgus and varus by holding the leg in the axilla. One time we do it in extension, we do a valgus force on the knee, and then at the time of the 30-degree flexion we do a valgus or varus force testing the medial and lateral collateral ligament. You have to compare it on both sides for the excluding the ligamentous laxity. The other test for ACL is with the knee 90-degree flex, holding the knee by from the upper part of the tibia by both hands with the foot is in neutral position. The anterior translation, excessive anterior translation means the ACL is ruptured. You can perform the posterior drawer test at the same time. The second test for the ACL is Lachman test, is to flex the 20-degree knee of the patient and supported on the knee of the examiner, holding the leg from the femur and from the upper tibia by each hand, making to-and fro motion up and downward. Excessive motion indicates lateral ligament injury. The third test is pivot shift, is to elicit the sense of the click, which is the sense of reduction of sublux lateral condyle of the tibial plateau during extension and medial rotation and abduction. The PCL, first you have to inspect the PCL, the posterior sagging of the tibial tuberosity, by inspecting a flexed knee 90 degree from the side. So and then you have to perform the posterior drawer test by flexing the knee 90 degree with the foot supported in a zero position, pushing backward the knee, demonstrate back posterior drawer test. This is the quadriceps active test. This is to correct sagging. We ask the patient to push his leg against resistance to correct sagging. And the fourth test for the PCL rupture is a chair test or Jody-Fry chair test to exaggerate sagging by the effect of the gravity when we put the leg both on the chair. External rotation rotatory test, once there is two ligaments are ruptured, for example the ACL and medial collateral ligament. The external rotation rotary test is helpful to demonstrate that. So we flex 90 degrees, rotate the foot 13 degrees and pull upward of the tibia. See, the tibia is projecting or translating forward. And for internal rotation rotary test, for examination of ACL and LCL when they are injured together. It is the same like a drawer test, but the difference is the foot is externally and internally. This is posteromedial instability test, and this is the posterolateral instability test by pushing the upper tibia backward on internally rotated leg. And this test, what we call it external rotation recurvatum test, holding the legs from big toe. So if the posterolateral complex has been injured, the leg is going into varus external rotation and hyperextension. Don't forget to examine the pedal pulses for dorsalis pedis and posterior tibial artery. And then you have to perform a neurological examination such as a straight leg rising test. Sometimes the referred knee pain coming from the back. And then you have to perform a knee jerk and the ankle jerk for any neurological deficit. And you should compare it with the other side. You have to examine the joint above for examination of the hip, examination of the pelvis for any disruption of sacroiliac joint or symphysis pubis by sacroiliac examination. Palpate the abdomen by deep palpation for any deep-seated mass. Then examination in a prone position, you inspect and palpate the popliteal fossa, the same like anteriorly. You palpate for any mass, any visible dilated veins, varicose vein, palpable pulsation of the popliteal artery. We have two specific tests for the knee. One is Epley grading test, is axial compression on a flexed knee 90 degrees supported by the knee of the examiner with a medial and external rotation. And this test is used for the examination of the meniscus teeth. Epley distraction test. This test is to distract the tibia upward on flex 90 degree for ligamentous laxity or injury. And lastly, you have to examine the back for any malalignment, tenderness by percussing deeply over the spine and the sacroiliac joint for any deep tenderness. These may give a refer pain to the knee joint. Sometimes if the knee joint is normal, you have to examine this structure. Don't forget to examine the femoral stretch test, which is a test for a disc prolapse, for example, at the level of L3 and 4. And lastly, you have to thank your patient for his volunteer demonstration for the examination. Thank you very much. And this is, I